Okay, welcome everybody to my lecture that I'm going to do today on bone disease and nutrition. So this is part of the clinical nutrition module here at Queen Margret University. So I'm Dr. Andrew Chappell, and without any further ado, let's get on with this. And today I'm going to talk about both the management of bone disease, and I'm also going to talk a little bit about some of the research in bone disease. So, by the end of this session, hopefully, you'll be able to describe different types of bone disease. You'll be able to discuss the pathophysiology of different types of bone disease. You'll be able to describe how bone diseases are managed, the ones that we're going to talk about on here, and discuss bone diseases in the context of extreme environments. So I've got some research here that I'm going to talk about, which hopefully you'll find interesting. Now, I've got a bone here. It's a joint. This looks like a pelvic hip joint. And if you look at a bone, what you can see here is that bones are not solid structures. They're honeycombed in their appearance because if they were great big solid structures, that would make them very, very heavy. So they've got this kind of honeycomb type appearance, and for much of you this will be revision. But it also allows us to have blood vessels and bone marrow within the bone structure itself. Bones themselves are predominantly made up of calcium and phosphorus. And if you look in the literature, you'll get estimates of something in the region around about 50 to 70% of them are made up of that. Now, before we get this presentation underway, stop and have a little think. Pause this video. What do you think are the main public health issues relating to bone disease, and how can we manage them nutritionally? Now, I've already mentioned that bones are predominantly made up of calcium, phosphorus. So from a nutritional standpoint, we've already got a few ideas probably running through our head about how we could potentially manage some potential bone diseases. So have a think. Maybe make some notes. Okay, so here we go. Here's a bone. And this will really be revision for many of us here. But this is your classic diagram of a femur. So you've got the diaphysis, which is this big long area that sits between the epiphyseal. So you've got the proximal, which is closest to the body. We've got the distal, furthest away. And at the epiphyseal, you typically have what we call the epiphyseal plates in children, and this is where your growth plates are. And at this point, these plates are not quite fused. They're still cartilage, and over time, that cartilage hardens, becomes mineralized. So it becomes this hard, what we call compact bone. That's the tough stuff. To say bones are not just solid structures. You can see here we've got the spongy bone, which is pitted. It's got gaps in it that allows us to have blood vessels running through them so we can supply nutrients to the bone so that cells can travel through the bone as well. We've also got within it yellow bone marrow, and this is where our progenitor cells, our stem cells, live. And these cells, they'll go on to become many different types of cells within the human body, just depending on what is required of them at the time. We've got osteoblasts and we've got osteoclasts. Osteoclasts, these are specialist cells which break down bone tissue, so they demineralize bone. We've got osteoblasts, these are specialist cells which will build up bone tissue, okay? And we've got this constant metabolism going on between the osteoclasts and osteoblasts, whereby we're always laying down new bone tissue and replacing old bone tissue. If we need to liberate some calcium within our body for some reason, for example, maybe we need it for muscle cell contractions, perhaps what we're going to do there at that point is we're going to mineralize take some calcium from the bone so we get an upregulation in our osteoclast and osteoblast activity. Okay, so an important concept in bone health is this idea of peak bone mass. Okay? So, in our younger days, as we grow, it's very important for us to lay down as much bone mineral density and achieve as much peak bone mass as we possibly can. So as we grow as children, we have an acceleration in our growth curves, and at the same time we get a concordant increase in the peak bone mineral density and our ability to lay down our bone mass at the same time. Now, a variety of things will relate to increasing that peak bone mineral mass. So we've got things such as hormones, so testosterone is a crucial one in males, estrogen is a crucial one in females. And you can see on our graphic, as women come into the menopause and we have a reduction in the amount of estrogen that's being produced, they can start to lose bone mass more rapidly. Lots of lifestyle factors contribute to us obtaining peak bone mass as well. So, weight-bearing type exercise is obviously extremely important for us to obtain peak bone mass. So that's things like running, lifting weights, doing yoga, for example. Anything where we're weight-bearing is extremely important for building bone mineral density. Diets which are high in calcium, vitamin D as well, are extremely important. So we're talking about fat-soluble vitamins. They're going to be very helpful for us to make sure that we've got sufficient vitamin D in our diet and sufficient calcium so we can be absorbing that calcium with our vitamin D alongside it. Sunlight exposure is important for helping us to absorb that calcium. So if we cover up our skin, if we've got dark skin naturally, then that's going to lead to us being able to not absorb as much calcium because we're not getting as much vitamin D exposure. Certain prescription medications, drug use, anorexia nervosa, alcoholism, gastrointestinal diseases which might impair, for example, our ability to absorb nutrients. These things are going to contribute towards us having a suboptimal lifestyle like our graphic shows here. And as we age, you can see that we can end up losing some of that peak bone mineral density, and as a consequence of that, we're at risk of things like osteoporosis. So the graph, as you can see, it goes something like this. We obtain as much peak bone mineral density as we possibly can in our early teens up to our early 20s. We then try and maintain that as much as possible into our 40s and into our 50s before our hormonal balancing as we start to age starts to decline and we start to lose peak bone mineral density. Provided we've built up enough peak bone mineral density when we're younger, then that is a protective factor against us getting conditions like osteoporosis. Okay, so this is just more of what I've mentioned already. You can pause this video here if you'd like. The graphic on my left-hand side, which is going to be on your screen on the left as well, you can see illustrates this gain in peak bone mineral density as children age over the years. Thereafter that, we've got another table in here which emphasises the various different conditions which are associated with impairing potentially peak bone mineral density in children and adolescents. So again, crucially important that we avoid a reduction in bone mineral density when we're younger, and we try and obtain as much peak bone mineral density to ensure that we avoid things like osteoporosis in later life. Okay, so moving on now, I'm going to talk about different bone diseases. So the two main bone diseases I'm going to talk about here are osteoporosis, which I mentioned already, which is just abbreviated to OST, and osteomalacia, which I have abbreviated to OSM. Now, osteomalacia, which we'll talk about, presents in children as rickets. Okay, so this is the bowing of the legs. Okay, so it's the same condition, same pathophysiology. It's just that we call it rickets in adolescents and in children. Now, osteoporosis, I've got two different images on here. So the one on my far left-hand side, that's osteoporosis, and this is where we get brittle bones and we lose total peak bone mass. So the skeleton declines in its total amount of mass. Okay? Whereas osteomalacia is different. This is whereby we have a deficiency in vitamin D, whereby it's a dietary issue, or potentially it is an issue associated with a lack of sunlight exposure. So this was a real issue back in the 20th century in slums in parts of Scotland, whereby children were getting low sunlight exposure, had poor diets, and because of this they were having a deficiency in vitamin D, and vitamin D, as we know, deficiencies result in a lack of our ability to absorb calcium from the gut. And what happens as a consequence of this is we get a lack of mineralization of the bone, okay? So there's as much bone there, it's just not mineralized correctly, and as a consequence of this, the bones are soft. And what happens in a infant and adolescent which has got bone mineral density issues is that their legs bow under the weight of the top portion of their skeleton and their upper body from here. In adults, again, the softened bones mean that you can get malformation of the skeleton, you can get defects of the skeleton as well, and this can affect the quality of life. This can also cause, as a consequence of it, lots of muscle pain associated with vitamin D deficiencies as well. So osteoporosis, this is loss of bone mass over time. Osteomalacia, this is the demineralization of the bone over of time. Osteoporosis typically affects women more so than men, and again it is because of the lack of ability to obtain that peak bone mineral density compared to men from here. And I've mentioned some of the different factors which can cause bone disease in both instances from here. There are other conditions. So you've probably come across rheumatoid arthritis. I mention this because this is a condition which affects the skeleton. So it does affect the joints. And this is whereby you've got a immunological disorder. And what's happening is you've got systemic inflammation, so the immune system is switched on all over the body, and it targets the joints, causes swelling, causes inflammation around the joints. It can be very, very painful. We can get issues such as synovitis, so the synovial fluid within the joint becomes inflamed. You can also get bursitis, tendinitis, where around the joints it becomes extremely inflamed. Now, over time, this can lead to osteoporosis around the joints as a result of this sort of chronic remodeling which takes place, so that osteoblasts and osteoclasts are always hanging around there. To manage these conditions, usually immunosuppressing drugs are used, glucocorticoids are used, and this can lead to a breakdown in the bone mineral density as well, or rather a loss of bone mineral density. Around about 30 to 50% of patients with rheumatoid arthritis also end up with osteoporosis as well. So rheumatoid arthritis, different from osteoporosis, presents as an immunological condition, but can no doubt lead to issues of osteoporosis as well. Osteoarthritis is a different condition, so not the same as rheumatoid arthritis, which is systemic. Osteoarthritis is typically caused by issues around joints, okay? Usually caused by wear and tear. And I've got up here again a couple of athletes. Doesn't have to be female athletes, it can be any type of athletes. I know myself from doing lots of exercise down the years. What happens is you can end up with lots of wear and tear, and I know my joints, particularly around the discs in my back, I've probably got some cartilage loss here in my lower discs, and as a consequence the bones kind of are rubbing together and causing inflammation as a result of the narrowing of the space. Okay, so it tends to be localized around certain joints rather than a systemic immunological condition. Okay, so that's osteoarthritis we're talking about here. Okay, so osteoporosis, defined by what we call T-scores and Z-scores. Okay, so if we're to clinically define osteoporosis, then what we do is we use something called a DEXA scanner here, okay, dual energy X-ray absorptometry, okay? So specialist X-ray machine. And you can see in the graphic again on the far left, we've got what normal bone looks like, and you can see that's that spongy bone, and then you can see the osteoporotic bone where there's a loss in total tissue in that region there. And what we do is we scan different points on the skeleton, so usually it's the neck, the vertebrae with the discs, the hip, the wrist, and the ankle are scanned. And then what you do is you compare the score that you got to a healthy adult, okay? So you get what's called a T-score. So a T-score is used to sort of characterize postmenopausal women, men over the age of 50 as well. And what we're looking at is how does your score in terms of total bone mineral density compare to the normal bone density, a normal healthy range. And it's based on standard deviations and how many standard deviations you are away from that normal healthy range. So if you've got a T-score of 1 standard deviation away from the normal healthy range, which is a 0, then we see that you say that you're in a osteopenia range, okay? So you're below average, you've not got osteoporosis, but you're in that sort of danger zone, if you like. If you drop down to below 2.5, so minus 2.5, you then fall into the osteoporosis range, okay? We use Z-scores for pre-menopausal women and for men under the age of 50 and for children. So it's the same concept, it's just the standard that we're comparing these people to are different, okay? Now, for every increase of 1.5 to 2 on your T-scores, or rather every 1 point drop in your T-score, you've got a 1.5 to 2 increase in the chance of a fracture or a break. So it's serious stuff. And I'm going to go on and talk about that. So this is data from the British Medical Bulletin, from a paper that I got on osteoporosis prevalence, mortality and cost. And it's an issue. So over 2 million women alone in England and Wales are living with osteoporosis, okay? And as you move from 50 years old, we're only around about 2% of the population have osteoporosis, to 80-year-olds, almost 50% of the population have got osteoporosis. And if you imagine back to that peak bone mineral density graphic, which I showed you earlier on, as we move up to 50 and our bone mineral density drops, then you can see based on our scoring system how more and more people are likely to have osteoporosis. 1 in 3 women, 1 in 5 men are likely to sustain an osteoporosis-related fracture in their lifetime. So as you get older, odds are more chances this is going to happen. White men and women have got an increased chance of fracture compared to other ethnicities. So black Caribbean, black British, less likely they obtain higher peak bone mineral density. Curiously, because of their skin colour, they've got a reduced ability to increase absorb vitamin D from sunlight. Vertebral fractures are interesting because they're harder to detect. Now, the table that I've got here from the archives of osteoporosis, you can see here we've got cases per year and we've got lifetime risk of fracture in terms of different percentages. You can see that females are more likely again to have fractures, particularly around the spine. Men less likely so. And in terms of hospitalisation, even though spine fractures are the highest, they're the least likely, down at 2%, to end up in hospitalisation. Now, if you look, you can see you've got relative survival scores. So if you end up having a hip fracture, in this particular table, chances of survival are only around about 17%, because only 83% of people with that hip fracture associated with osteoporosis survive. Collective burden of this is 37 billion in terms of the GDP. I've got some data here from America. It's 17.9 billion a year. From the UK, it's £4 billion per year. That's the economic cost of this. Again, this is an issue, particularly since we're an ageing population. So this is data from the Office for National Statistics. Think about the burden on the NHS, the eventual cost of this, what goes into trying to adapt people's homes, how many days lost in terms of recovery for people's livelihood, etc., are going to be associated with this. So, back in 1972, you can see you've kind of got these pyramids, whereby at the bottom the demographic kind of show that we've got more young people than old people, because at the peak we've got less people at 90 years old. As we move up to 2022, you can see it's kind of getting fatter in the middle, because we've got more people living in middle age. And then as we get to 2027, we can see you've got less young people again, more older people, and again more people circulating around that sort of middle age. So by 2072, the ONS is projecting that almost a third of the population is going to be 65 years or older. So there's major consequences of this associated with potential bone disease on here. And you can see I've got the walking stick reflecting frailty, fractures, potential higher mortality risks. Again, more data for you here on this one in terms of osteoporosis complications. This is coming from the National Institute of Health and Care and Excellence. If you're going to hospital with a hip fracture, almost 20% of those cases, backing up that other data that I showed you earlier on, end up in fatality. Okay, so osteoporosis can be a killer. So it's extremely important that people manage to have high peak bone mineral density. Okay, if they survive, only 30% actually recover. 50% end up with some sort of disability, okay? And you can imagine how that potentially affects quality of life. The next fracture you have, there's a 10-fold increase risk in mortality. So if you're one of these people that ends up disabled, so half of the people that get those hip fractures end up not fully recovering, your likelihood that you're going to end up dying after the next fracture, again, increases significantly. There's other complications as well, so you've probably seen this in terms of frailty, so people lose height. This has a negative effect on your ability to breathe because you're compressing the spine at the same time. It also negatively affects the gastrointestinal tract. You're living with lower back pain, you've got loss of mobility, loss of confidence as a result of these sort of things. So again, high bone mineral density is important to avoid these things. So that's osteoporosis. So osteoporosis. And I'm going to talk about how you manage these things later on. So, as I mentioned already, it's a lack of mineralization of the bone which is happening here with this condition. So we're ending up with soft bones, which leaves you vulnerable again to fractures. And again, I've already showed you the data on the fractures. The difference with this, however, is that this is caused by a lack of vitamin D in the diet or sunlight exposure to vitamin D, which negatively impacts calcium absorption, which again ends up creating these softer bones. If you look at this graphic on the far left hand side, the angles which are being pointed out here with the arrows, these are called the looser regions of the bone. This is around the epiphyseal plates, and this is where the strain is being taken from the skeleton, and you're seeing the bending of the skeleton because it lacks that structural strength on here. You can test for osteomalacia beyond looking at the sort of physical presentation. If somebody's waddling, they've got poor gait, for example, from here, because you can measure serum vitamin D, you can measure things called, you can measure calcium, but you can also measure parathyroid hormone as well, because maybe you've got enough calcium, maybe you've got enough serum vitamin D and sunlight and things like that coming in, but parathyroid is an important hormone which helps us absorb that calcium, therefore laying it down into our bone and allowing the mineralization to take place. I've mentioned a lot of this already. So vitamin D helps us with calcium absorption. Deficiency leads to a lack of calcium absorption. There's different types. So you get phosphopenic and chalcopenic rickets. One is a lack of phosphate, one is a lack of calcium or calcitrol. Calcitrol is the active form of vitamin D, which allows us to absorb calcium, and it's stored as in the inactive form as calcidrol. If you end up, as I mentioned already, with a lack of parathyroid because perhaps there's some sort of disease, maybe there's a parathyroid tumor or there's just something going on, maybe the thyroids have to be removed for whatever reason, this can negatively affect the calcitrol, which then has an impact on the calcium absorption, and we might see negative impacts on calcium excretion and phosphate excretion as well. So this is the metabolism. This is what's happening. So we can obtain vitamin D from the diet. And vitamin D you get from sunlight, from the UVB rays, causes the conversion of something we call 7-dehydrocholesterol in the body into the active form of vitamin D, which is 25-oxy-D-calciferol. And I'm going to say that only the one time from here. You'll see the abbreviated term up here on the slide from here. We can also obtain vitamin D from the diet. We can get it as vitamin D2 and vitamin D3. D3 is the best form. If you were going to supplement, that would be the one that we would suggest that you uptake. Once we get in our diet, or we have it in our skin, vitamin D is transported through lipoproteins, so as part of cholesterol. It goes to our liver, and then it's in our kidney where we'll have the calciferol, okay? That's our vitamin D. Parathyroid hormone, that regulates the calcium uptake, so what that does is it converts the calciferol into calcitrol, which allows you then to go on and to absorb more calcium in your intestine, and from that point there you can then incorporate that into your bone as part of the metabolism from there. So we can measure 25-hydroxy vitamin D. So that's one way you can do it, and there's a nice graphic on here which allows us to sort of define deficiency or not. There's 3 stages. We've got deficiency, insufficiency, and sufficiency. So insufficiency is not quite deficiency. We're getting there. And you can see we've got a few different definitions of what counts as sufficient. I was looking around to try and find a nice British definition of it, but the NICE guidelines sort of direct us to these sort of cut-offs from here. So there's not a universal agreed upon definition from here. Other things you can do clinically alongside diagnosing with serum 25-hydroxy is asking questions about sunlight exposure, because that'll give you a pretty good idea of what's going on. Is someone likely to be vitamin D deficient or not? You can ask about the vitamin D content of the diet, how much fatty foods they're potentially eating as well. You can look at the calcium content of the diet as well. You could do x-rays at the same time and look at the calcium phosphate and alkaline phosphatase content of the bone. Probably need an MRI or something to do that. You can look at parathyroid levels as well. Okay, so how do you manage these bone diseases then? Well, if you go onto the National Institute of Clinical Excellence again, for osteoporosis, I mean, the best way to solve a problem is not to have the problem in the first place. So I've kind of explained this, but if we are faced with a problem and we've got, say, girls or adolescents or women, and I'm focusing on these because these are the highest risk groups, with amenorrhea, so they've lost the menstrual cycle, or they've got low estrogen levels associated with potentially the menopause, then they're potentially at risk of developing osteoporosis. If you've lost the menstrual cycle, then chances are you're in a state of low energy availability, high stress, and low estrogen production, and all these things are potential risk factors for causing the demineralization of the bone. So, what we should be trying to do is, first off, categorize the potential fracture risk. So if you can do the DEXA scan, you can work out what the T-score is or the Z-score, right? This is particularly important if you're working with girls because you want to establish what the baseline measurement is, so then you can have another measurement later on, and then you can make a comparison to see if there's deficiencies or if we're recovering from this. Optimal lifestyle. So avoiding things like excessive alcohol, smoking, the balanced diet, potentially more calcium, more vitamin D in here, making sure we've got a normal body weight at the same time. I've highlighted weight-bearing exercise because it depends on the severity of the T-score and the Z-score, because it could be potentially contraindicated, but generally speaking, weight-bearing exercise is a good thing for us because it increases our bone mineral density. Our body's got to adapt to the stresses placed on it, and one of the ways in which it adapts is it builds thicker and stronger bones. If we're dealing with someone who's got an eating disorder, then we should always refer. Okay, I'm not going to say any more on that. And if we can't correct our vitamin D deficiency, again, supplementation, and I've got some information here on supplementation, and ensure adequate calcium intake. We can usually get sufficient calcium from the diet. There's usually not a need to supplement, but I suppose it can potentially be an option for us. Ever taken HRT? Might be worthwhile seeing an endocrinologist, seeking specialist advice. We can potentially have drug prescriptions, although as nutritionists we're not prescribing them, which will increase the, or rather decrease the breakdown of bone tissue, the reabsorption or demineralization. Something to be aware of is something called relative energy deficiency syndrome, or REDS. And I touched on this, but this is whereby you might be potentially working with an athlete, and this used to be described as the female athlete triad, and this is whereby we've got an individual who's doing a high amount of exercise and activity, training, sport, etc., but maybe not consuming enough nutrients, so calories, vitamin D, calcium, etc. And as a consequence, we can see all of these potentially negative effects happening to the female body, such as the loss of the menstrual cycle on here. They can end up with extremely low body fat levels as a consequence of having low energy availability, which can then end up to having profound effects on the endocrine system, such as increases in cortisol and decreases in estrogen, again negatively affecting potentially bone mineral density. If this is addressed by rest, detraining, increases in energy intake, then potentially you don't have low energy availability, and then the menstrual cycle can come back. So it's something to be aware of when we're thinking about why someone might have lost, or some woman might have lost her menstrual cycle. The good thing about this, however, is that when you're dealing with athletes, usually they're doing a lot of weight-bearing exercise, and that is a protective factor against that loss of bone mineral density. Now, in terms of supplementation, vitamin D is preferable to D3 is preferable to D2, just seems to be absorbed better, is more bioactive. I mentioned pharmacological treatment, so potentially we're looking at drugs which will inhibit the breakdown of bone tissue, so that when we can obviously accumulate more bone tissue. And then there are some supplementation regimes. We've got what's called a loading dose, which you might take for the first month, and it's 300,000 international units separated weekly over 6 to 10 weeks. So that's split up. That's what we're looking at potentially taking in over the 10 weeks. Thereafter, you're moving to a sort of 800 to 2,000 IU, so that's international units dosage on the daily thereafter, until content has been, vitamin D deficiency has been curbed. Other things to consider, so I've said a high calcium diet, so that's nuts, that's dairy products obviously, on here, green leafy vegetables, eggs, generally higher fat foods are useful for this. And then a high vitamin D diet is again eggs, fish, dairy, again good sources of vitamin D, alongside increasing sunlight exposure. Sunlight exposure is a curious one. We just have to be cautious around sunburn and not getting too much sunlight exposure which might potentially damage your skin. This graphic as well is also useful because it sort of highlights the potential risk factor associated with skin cancers as well, and an ability to absorb vitamin D the darker your skin colour is. Okay, let's talk about some research then. So, I've already mentioned vitamin D is important. So sunlight is important, and enough vitamin D is important in our diet to allow us to absorb calcium. If we can absorb the calcium, then we can get a high peak bone mineral density alongside doing weight-bearing exercise and having a healthy lifestyle. But what happens when you do activities, occupations, or you live places whereby there's zero sunlight exposure, like if you live in a submarine, or if you're in a pressurized capsule and you're a deep sea diver and you've got to spend 3 months in one of these containers at a time, or you live in the Arctic Circle, do you get more fractures? Likewise, what happens if you take all the weight bearing out of the equation? What happens to your bone mass then? So if you live on the International Space Station, how good is that for you? And what does that mean if we want to travel to Mars in the future, if that's going to take us 2 years? What things might we have to consider? So I think these are nice examples because they highlight why vitamin D and weight bearing exercise are so important in bone health. So I've mentioned this already and I'm going to move on from here. So, the research in the submarines is interesting. And this is a systematic review here which looks at vitamin D status of submariners. Okay? Tells us what their starting vitamin D status is when they go out on these tours and what it is when they return. Now some of these studies, they're only going away for 30 days and then they're coming back. But they'll spend 30 days underwater, no sunlight exposure at all. Or they'll spend 90 days underwater, no sunlight exposure at all, okay? What it doesn't tell us is what is their bone mineral density, what are they doing to address some of these things, how many fractures do these people have? And there's probably good reason for it, right? This stuff's top secret. You don't want to go around advertising how healthy or unhealthy potentially being a submariner is, or what you're doing to try and address these things, because there's national security interest here. So you don't tend to get that information. Now what we see is, unsurprisingly, pre-tour, these are the ranges from the studies. And there's 13 studies, they're all men. I don't know if that's a rule around submariners or not, or just people that want to be submariners. But I think there was about 300 to 400 men in this study. We've got 13 studies in total, and we're looking at levels around about 14 to 32 nanograms per milliliter. So some of these people are sufficient, insufficient, and actually deficient if we look at our classifications for vitamin D. Post-tour, when they come back, the levels drop. So they go from, at the lower end, from 13 to 7.9, and from 32 to 30. In terms of it as a percentage, go from 13% to 30% of being deficient, from 26% to 40% being insufficient, and then go from 60% being sufficient to 30% being sufficient from here. So there's a drop. Interestingly, one of these studies supplemented with vitamin D, 1,000 to 2,000 IU, so that was our standard protocol for people who are deficient in vitamin D after the loading phase. Did it for 3 months. It seemed to be quite useful for maintaining people's levels. However, not really any better than a placebo, believe it or not. So, that's what it finds. However, there is a recommendation that we should perhaps supplement these submariners and fortify their foods. Various interesting things as part of this study as well, depending on the overall latitude that the submariners are at. Also, seasonal variations as well are factored in, and you can go and look at it in your own time. The studies here. So, lack of sunlight exposure causes your vitamin D levels to drop, or does it? This is a study here looking at fractures, hip fractures, in the Arctic Circle and in Norway. So you can see here in our graphic, we've got Norway here. It's further north than the United Kingdom. This line here on our graphic represents the Arctic Circle. That's you within the Arctic Circle. So you're very not far north at this point, almost at the top of the pole. We've got Nordland, Troms, and Finnmark. These are different regions within Norway. And then you can have a look. We've got a graphic here down at the bottom, and the darker the colour, the higher the prevalence rate is for fractures per 10,000 people. The lighter the colour, the less likely you are to have a fracture. Now, the hypothesis is the further north you are, the less sunlight exposure you've got, the less sunlight exposure you have, the less vitamin D you're likely to get. The less vitamin D you're likely to get, the lower your calcium absorption is going to be. The lower calcium levels you have in your bones, the more likely you are to potentially have a fracture if you have a fall, particularly in a part of the world which is particularly cold and icy and so on. However, it doesn't bear out like this. Not if you categorise it, in any case, just based on the region in which you live in. Okay? In the south, we're seeing more fractures, and there could be lots of reasons for that. Higher population centres, maybe it's more icy, we're not sure. But the scientists in this particular study suggested that the reason was because those people living in the far north more likely live by the coast. The climate is a little bit more favourable by the coast rather than inland, but they're also more likely to have a diet which is higher in fish. Okay? And if we look at the traditional Norwegian diet, this Norwegian diet is high in vitamin D. So it doesn't follow that just because they're in the far north that they're going to be low in vitamin D despite the lack of sunlight. They're making up for it potentially in the amount of vitamin D they've got in their diet. So that's interesting. So what it kind of means is, if we've got enough vitamin D, we can potentially offset fracture rates. This study's cool. This is data from space travel. Okay, we've got a meta-analysis here looking at bone loss in space travelers. And some of this stuff goes back to the 1970s. So you've got the Gemini 7, you've got Apollo 8, Apollo 7 here as well. Apollo 14, they actually went to the moon on that one. And actually it's not really blinding, because if you know anything about the space program, you'll know who these people were that went on these missions. But in any case, what they've done on the far graphic here is they've split the body up into different regions. So you've got the skull, going down you've got the axial skeleton, so the upper torso. We've got the pelvic region, and then down at the bottom here we've got the lower body, the limbs. And what it's measuring is what happens to bone mineral density throughout the body. And what we see is there's a loss of bone mass around about 2%, 3% from the upper torso, a larger loss of bone mass, almost 5% in the pelvic area. The lower body, again, almost 3-4% in the lower limbs of the skeleton. So we're losing bone mass every time we go on these trips. The other thing that's happening here is, we've got this graphic, and this is an amalgamation of this research here, where they've measured these indicators. We've got parathyroid hormone, we've got calcitonin, which is a marker of vitamin D status, and we've got vitamin D. And we can see that over time, the 0 point is the starting point, that's point 0 if you're on planet Earth. As we move along this, there is a drop in all these levels. Now, I should mention these markers, these lines here, that's the standard deviation, that's the range. So some people are not seeing a drop, other people are seeing a drop. But the story on the whole is, we're seeing a reduction in vitamin D, we're seeing a reduction in the calcitonin, we're seeing a reduction in the parathyroid as well. Bone reabsorption, this is the demineralization of bone, goes up to 113% by 11 days after you've been in space. So you're seeing huge increases in the amount of bone breakdown. When you come back, you're seeing a massive increase in the formation of new bone compared to a 6% formation at 11 days, so 84%. By 2 to 5 years, however, some of these astronauts are never recovered. Okay, they don't get that bone mineral density back. They just don't, which is an important consideration because we see the same thing in anorexia nervosa patients. Sometimes after that bout of anorexia nervosa and they lose that bone mineral density, sometimes they never recover that bone mass on here. I should mention it's calcium metabolism, calcitonin rather, relates to calcium metabolism, not vitamin D metabolism. Can you do anything about this though as an astronaut? Well, kind of. So the graphic here you can see, this is an adaptive resistance exercise device. This chap here, he's got a suit on, there's something on his shoulders which is holding him down, he's got some chains in his hands, some handles, and he's going to pull on them, and that can replicate up to 600 pounds of pressure. He's effectively doing like a trap bar deadlift or like a dumbbell squat, if you like. So he's doing weight bearing exercise, and it's not uncommon for astronauts to also do lots of cardiovascular exercise as well, because we see a reduction in cardiovascular capacity. Now the graph here, what we've got is these are different points on the skeleton. So we've got the spine, lumbar spine, we've got the neck, we've got the trochanter, we've got the hip, we've got the wrist, okay? These are different points. The black bars, these represent individual data points. That's from the space station Mir, that was a Russian space station. I think that went up in the 70s or 80s and came down in the early 90s. And then across here we've got the 0 line, okay? So if you imagine that as, again, no loss in bone mass, everything stays the same. The little lines you see going across, that is the average. After that, we've got the circles, that's the ISS, with the use of exercise equipment. And then the next one along the triangles, that is the exercise equipment that is highlighted here in the picture. You've got a line again on there. And it's also got the use of bisphosphonates, which stop the breakdown of bone tissue. And what you can see is, when you introduce the drugs, and when you introduce the adaptive exercise, you can actually reduce the amount of bone mineral loss. Can't seem to negate it completely, but you can reduce the amount per month or per trip that someone's likely to lose. So weight bearing exercise, extremely important. Now this is a fascinating area. You can go off and you can read all about it, about nutrition in space and the challenges facing people doing nutrition in space, particularly from a food science perspective, right? And there's this paper here, it's recommending a few things that we need to do, because it's not just bone mass that you're losing, it's protein mass as well. So you're losing muscle mass as well. And if you ever see any images of astronauts that have done extended trips in space, then what you see happening is when they're getting out these capsules and things like that, is that they're really struggling potentially sometimes to stand up, and they're not in a great state. But before people go, it's recommended that there's some pre-screening, so it's a DEXA scanner to sort of understand where they're at with their T-scores and their Z-scores. Calcium and vitamin D supplementation and fortification of foods is recommended. Protein supplementation, the use of resistance exercise, and then there's got to be some sort of post-flight recovery protocol. Usually, probably involving some of these things here that I've mentioned already. So, with all that in mind, what can we take from this research, and how does it relate to bone disease and osteomalacia and so on? Well, a lack of vitamin D, or rather, a lack of sunlight exposure depletes your vitamin D. We can see that clearly. A lack of weight-bearing exercise causes a loss of bone and muscle mass, and it might never come back. Supplementing with vitamin D and a high vitamin D diet increases the amount of serum vitamin D, even in the face of low sunlight exposure. When your vitamin D levels are maintained, your chance of a fracture is potentially reduced. Supplementation of around about 1,000 to 2,000 international units for people with deficiencies seems to make sense. And again, weight-bearing exercise is effective at any age for maintaining bone health. So here we go, this is the summary. We want to get as much bone mineral density as we can when we're younger, and as we age, we lose that bone mineral density, okay? Women are at greater risk of osteoporosis and osteomalacia, and that's because they obtain that lower total peak bone mineral density as well. People who have got potentially eating disorders, they've got malabsorption issues with their gut because of maybe irritable bowel syndrome or inflammatory bowel disease. The menopause, the andropause, parathyroid hormones or genetic conditions can all influence that bone mineral density, as well as some drugs can impact on this as well. Fractures related to osteoporosis can be fatal, okay? Quality of life will be negatively affected by osteoporosis, osteomalacia. Osteoporosis, that's brittle bones. Osteomalacia, think about having the soft bones as well. Vitamin D, high calcium diet, exercise prescription, these are all used in the management of osteoporosis and osteomalacia. If you want some further reading on this topic, there's some interesting stuff you can go and have a look at. So, food fortification with vitamin D, should we just fortify all our foods with vitamin D? Vitamin D is always a hot topic. It's related to the immune system as well, potentially getting sick, less colds, less viruses, etc., because it helps us in that respect as well. But maybe we could offset osteoporosis, etc., particularly since we've got an ageing population. So, should we start doing this? So that's an interesting topic. Where are we at with vegetarianism and veganism with osteoporosis? This is an interesting paper here. Shows that if you're following a plant-based diet, you're at a higher risk of being deficient and of having fractures. If you go and have a look at the BNF, you can see some treatment guidelines, etc., related to osteoporosis. Okay, that's us there. Finished here with this lecture on osteoporosis, osteomalacia, bone disease and nutrition. If you enjoyed this or you just want to give me some feedback, scan the QR code now and it'll take you a little form and you can go and leave some feedback for me on there from that. And hopefully you enjoyed this lecture. I look forward to hearing from all of you. Goodbye.